Here we are on a 90% humidity day, so we've done both ends of the spectrum. And so we're very happy with the way the series is going. We've had a lot of speakers out here. If you've not been with us, go to the website, either the library's YouTube page or our YouTube channel to see the previous ones. We've covered, we think, everything you need to know as a primer. Tonight, we're very happy to have two terrific panelists. Dr. Tzivia Moreen is passionate about partnering with patients, families, and the multidisciplinary team to provide care for older adults that prioritize quality of life and patient preferences. She is the geriatrics attending physician for Stamford Hospital's inpatient consultation service and acts as a consultant for older adults hospitalized at Stamford Hospital. Dr. Moreen trained in primary care and geriatric medicine at New York Presbyterian Hospital, Cornell. She and her husband are blessed with 4 terrific kids who are the center of her universe. And in her spare moments, she loves to be outdoors and spend time with friends and is very involved in her synagogue community. Dr. Alison McElhone graduated from SUNY Downstate in 2000 and completed her internal medicine residency and geriatrics fellowship at SUNY Stony Brook in 2005. She became a board certified in hospice and palliative care medicine in 2012. She joined Stanford Health Medical Group in 2019. Prior to that, she worked for the Veterans Affairs Hospital in Northport, New York, and Central Michigan University in Saginaw, Michigan, and for Griffin Hospital in her Wilton, Stanford practice. She is a specialist evaluating patients who are referred for cognitive concerns, mood or behavioral disturbances, mobility and functional decline, and other geriatric. Thank you both for joining us.
Thank you for having us.
So we are focusing on, we'll get in and out of hospital a bit, but that is the subject that we're going to. Broadly, is hospitalization more dangerous for a senior than the rest of the population?
That's a great question and a big one. So I think a lot of the topics that we're going to talk about this evening will address aspects of that. Broadly speaking, there are certain complications that we are more concerned about for older adults. So it's not so much that it's more dangerous because a lot of older adults have medical conditions they need to be treated in the hospital, but that there are special considerations and older adults might be at higher risk for certain complications and other outcomes being in the hospital. So we can get into a lot of that.
I'm in agreement.
Okay.
We work together.
So it's been said, I've been told, so a hospital is the last place someone with dementia should be going. But really, how do we make the decision whether we should be going to the hospital with someone who has cognitive impairment and when we might want to take a different path? And what that path might be, it's not like it's a whim, we need that. When do I make that? How do I make that decision?
So, so dementia, I mean, there can be a whole list of concerns that maybe somebody has to think twice about hospitalization, but try to discuss, particularly if I'm thinking about somebody with dementia, I do try to discuss with the families and the patients as well what their previous experiences might have been. And you kind of have to step back and look at the big picture. If this is a, very elderly person, with dementia who's, frightened by, the emergency room, all the, going from their safe environment, wherever that may be, into this, bustling, environment where they're poked and prodded, I think families rightfully think twice about, sending their family member there. And there's a lot that we can try to do to understand what is perhaps causing an acute illness and maybe getting some, treating in place. So I do try to do that.
Dr. McElhone was also stressing the importance of calling your doctor. So I think if we're thinking about whether to hospitalize somebody with dementia, and it's true that there are a lot of considerations and there's a chance that their dementia, they could get worse in the hospital, or they could experience complications like they may be more agitated, have more behavior concerns in the hospital, they're away from home, different caregivers, acutely ill, and so that could be really concerning. But a few things that we should talk about. So one is, what are the goals? So Dr. McElhone can talk a little bit more about how we address that even before somebody comes into the hospital, because it may not be consistent with what we want to do for that person to put them in the hospital. And then also the critical point of partnering with your doctors, particularly the primary care doctor or geriatrician if you have one, because they should be the first call, unless it's an emergency where you can see you have to call 911, and we can talk about what that might look like, but otherwise, call your doctor first. Even if it's the middle of the night, there's somebody on call who can talk with you about whether to go to the hospital. Do you want to talk a little bit more about goals?
Absolutely. And I will say, you know, when I see somebody in the office, a patient in the office for the first time, one of the things that we do in our very comprehensive visit is talk about what's important to that patient and the family and review goals of care. You know, are they okay with going to the hospital? Are they, you know, is it more important for them to be in the comfort of their own home with their family? You know, what's important to them, and you know, and that might include also things like code status, you know, whether or not to do aggressive treatments like CPR. So we do include that in our first visit, and whenever there's a change in condition. So we kind of get to an idea of what's important to patients and families. And I think it's really important to do that on the outpatient side with somebody ideally who knows you and you know, you trust and can help you and your family make a decision.
That's a really critical point, which is that we want to start conversations when people are stable in the outpatient setting with a doctor who knows them. And that way that can help guide our decision making if they do need to be hospitalized. Calling your doctor also is really important because in a lot of cases that the doctor or their covering doctor could maybe see the patient for an urgent visit in the office and avoid being hospitalized. So I would definitely really.
In a lot of these cases, so something's happened. Now I'm scared.
Yeah.
That's my mom. That's my wife. She's on the ground, and I have to make this call. People have told me the hospital is scary, and when are we gonna do this? I've gotta make this decision, and I don't know where. On something as simple as a fall, because it happens so often, right? Are there best practices that I should know that this is a no-brainer? Relax and try to dial back the tension, because when you're giving off the tension and anxiety, that's being exacerbated with the person, especially. So how do I make that call? What do I consider?
Well, I mean, if you're specifically talking about a fall in an outpatient setting, I mean, there are certain instances where you need a physical evaluation, and I certainly think as somebody that's, you know, on a blood thinner or has had head trauma or is having physical pain, that warrants an acute evaluation. So, you know, we don't want to wait too long on that kind of a decision.
I think this also brings us to a few additional points we should get into. First of all, if you have to end up in the hospital, right, so how do we reduce the risk, right? And what can you do? And there's a lot of things we could talk about to reduce the risk of complications or just having worsening of dementia symptoms, behavioral symptoms. So let's get into that in a bit. And then there's also a bunch of touch points where you might make decisions. So let's say if somebody's on the ground, right, and especially if you can't get them up, they're in pain, they seem injured, they're not behaving normally, you have to call 911. And in that case, EMS can start working with the family and the patient to decide about whether to transfer to the hospital. In the emergency department, and at Stamford Hospital, we have a few features of our care in our emergency department in particular, which are, we're actually certified geriatrics. We have a certification in geriatrics care in the emergency department. And so there's an additional level of being able to communicate with the clinicians about whether somebody has to then be admitted to the hospital. So there's different points at which different clinicians can help families decide about that.
Well, and that raises an interesting point too, that I just figure all hospitals are the same. And might have a good reputation, whatever, and I don't want to get into a judgment piece, but many of us live in areas where we could have a coin flip. You know, from here, I can go Stanford, I can go Norwalk, I can go a little further east, I could go to Bridgeport, I could go, there are certifications and things like that. Can you talk about those a little bit, and how we find out what a certain hospital has, again, so I can do my research?
Yeah. Okay, so Dr. McElhone probably has more familiarity with some of the more northern hospitals. I'm personally at Stamford Hospital, and so we have our geriatrics consultation service, which is really invaluable because we can actually work with the primary team caring for the patient to address any geriatric specific concerns. We also have in our emergency department, we have right now one nurse, we're hiring a second one. who's specifically trained to help triage older adults and try to avoid hospitalization. There are some people who come into the hospital and they have to be admitted. They have an unstable infection or cardiac condition and they just have to be admitted. But in a case where that person might not have to stay in the hospital, our nurses trained to work with families, do some additional evaluation, and then get some resources on board, whether that's home care or physical therapy, etc. So those are some advantages at Stamford Health. There are some hospitals that have other levels of geriatric care. So Paul had asked about what is an ACE unit. So an ACE unit it stands for acute care for the elderly, which is a specific unit of the hospital when somebody is admitted, where an older adult could be admitted to that specific unit. And there are design features of an ACE unit. It's run by physicians or clinicians who are familiar with geriatric care, and it's designed to be more friendly to older adults. We don't have a local ACE unit as far as I'm aware, and I'm not even sure if Bridgeport does. We do not at Stamford Health, and Greenwich and Norwalk do not. And Greenwich and Norwalk hospitals also, I think the care that they can offer in geriatrics for inpatients is variable. It's not quite the same as our consultation service at Stamford. Do you know what else they have? Oh, Bridgeport does.
Bridgeport
has a
has a
really robust geriatrics program.
Yeah, they do. Honestly, I'm not familiar with Norwalk, though.
Yeah.
But it's certainly, when we talked earlier about doing the research before we're headed to the hospital, that these are things that we know now to ask the questions that what facilities do you have? If I'm the primary caregiver for an elderly person, I should do this. This is my lunchtime call while everything's fine, so I know my checklist. Okay, so we've decided we've gone to the hospital, we're going through that process. One of the first things that come, and we get a lot of calls on this, is admission versus observation. And this is one of those, that's the term, and it's really, really important, and it has a lot of bearing. There are insurance issues here, and there are also clinical issues here. So,
Okay,
I'm sorry, this is like, I'm not an inpatient,
So Elena Sapos, who's in the audience, is our nurse practitioner for the inpatient service and is also a case manager. So Elena, do you want to describe the difference? I don't want to put you on the spot, I'm happy to do it,
but she just did.
She volunteered.
The difference is that when you come to the hospital, it depends on your condition, your presenting symptoms and your condition. So the doctor makes a decision whether to, the difference for you as a patient, you're not going to feel it different because you're going to get the same treatment. You're going to go into the same room, you're going to get the same medications, you're going to get the same nursing, everything is going to be the same. The difference is in billing. So Medicare, they were trying to save the money. So what they decided to do is that certain conditions, when, let's say the patient comes in and they're not, it could be in the evening, somebody comes in the evening, somebody fell down with a person, they fell at home, and they seem to be okay, but when they used to be able to walk, now they can't get off the gurney and walk. So the hospital cannot send somebody home who is not able to walk. So they want to keep them for a few hours, between like 6 and 12 hours, sometimes up to 24 hours, just to keep them for observation, to see how the person is doing. Sometimes they may get a little bit of fluid, sometimes they may get like, antibiotic, Tylenol, some very light treatment, but it's just they don't feel like it's safe for a person to go home, or maybe the labs are a little bit off. So in this situation, this is called observation. So the hospital cannot charge, it all has to do with charges, what the hospital is going to charge Medicare or the insurance. So when somebody is admitted and, we're thinking, it's a more serious condition, then there's more reimbursement. When somebody comes under observation, they're just going to be there for a few hours for stabilization, then the Medicare will pay less. There's certain diagnoses that the hospital will bill, they will pay less. As a consumer, as a patient, you may see more, you may get a bill because Medicare won't pay for everything. But you already know that Medicare doesn't pay for everything anyways, but so there may be a little bit, but you won't feel it as a here, you won't feel a difference, you just feel it in your pocket.
Right, which is really a critical point, because you're gonna get the same care, the same medical team, it's just the Medicare billing. So Medicare gets to decide whether or not you need care in an acute hospital. So there could be a lot of conditions we could theoretically take care of at home. Let's say an infection, you could get antibiotics in pill form. You don't have to be in the hospital for that. But as Elena was describing, for older adults in particular, there could be additional considerations. If somebody fell, even if they don't have a fracture, it might be that they need more physical therapy before they can go back to how they were before. They need more care. We can't make that happen from the emergency department. We bring them into the hospital, watch them. Maybe we do a little bit more testing, but Medicare doesn't really like that, or at least they don't bill the same for it. The other implication is that if somebody might qualify to go to a rehab, so we're talking about subacute rehab, where you stay for a week or two, Medicare covers that for the physical therapy. In order to qualify for that, you need to have a 3-night qualifying stay, which means that you have inpatient status, admitted status, that's the same thing, rather than the observation status. So this gets really tricky for families because you know that the person fell, they should really go to rehab, they're gonna benefit, but if you don't have that qualifying stay, Medicare might deny it. So we do work really hard to try to work with patients and families to make this happen. And I can't emphasize enough that if somebody needs to be in the hospital because they need care, even if Medicare doesn't think they're medically acutely ill, they should be there so we can get them the right care, right? We wanna make sure they're safe. And so we bring people into the hospital to know that they're safe, even if Medicare doesn't think they have to be in the hospital. And then we'll have to just work on the finances later. It's sort of a cost of being an older person, but we want you to be safe.
Are there things that I should do, if I'm the caregiver and I brought somebody in, are there ways that I can advocate for admission, and how do I find out whether we're in? She said, I'm gonna be in the same room, I'm getting the same treatment. I'm panicked, it's all gonna look the same to me. Who do I ask when?
Yeah, it's the case manager is obligated to provide you with documentation of your status. So if you have the observation status rather than the inpatient admitted status, the case manager has to, within 24 hours, I think, right, has to give you papers that explain that. So that.
But it could also change, you could be admitted to inpatient, but then you recover fast. So Medicare has this rule also, like if you recover fast and the hospital doesn't have any reason to keep you, the original admitted you as inpatient, they can reverse that and make your observation. But you're gonna be informed, the case manager is supposed to inform you, let you know, because it's gonna affect.
And if that happens, I have to start, you talked about the 3-night overnight, so I have to pay attention to that and count how many points I'm getting so I can get mom into rehab?
Yes, but at least at Stamford Hospital, and I can't speak for other hospitals, but our case management is pretty good at working with you on this, right? So they'll tell you, okay, well, we're gonna keep her for 3 nights because we really want her to be able to go to rehab. It happens often that we change the status from the initial observation to inpatient admitted. Unfortunately, when people come in the hospital, we sometimes find more things wrong, and once we start treating that, Medicare will let us to then switch the status to inpatient, and you can become eligible for the subacute rehab.
So you mentioned case manager, I want to use that as a reason to move to and talk about the players, because it's sort of changed. The biggest one, and I'd like to talk about a hospitalist, because my primary care physician is not coming in to see me, and that's not my point person. You talked about a case manager, there's social workers, there are aides, there are nurses.
Well, a hospitalist is, it's a specialist that cares for people in the hospital. I mean, they're very,
No different than a cardiologist is heart, pulmonologist.
you know, hospital-based medicine is what they do. Are there fellowships in hospitals?
Not technically, but, so a hospitalist is an internist, trained as an internist, but then they start to specialize in hospital medicine, which is different from caring for people in the office, which is why this system is to your advantage, because you now have a specialist who can manage everything happening in the hospital, not your primary care doctor who comes for half an hour every day. That hospitalist is available all day. When that person is off for the evening, there's what's called a nocturnist, an overnight hospitalist, who has to cover the patients in case something comes up at night. So the hospitalist, they don't have special training per se, but they get more experience doing this. The other thing I would say, one way to advocate for yourself is to always ask people, who are you, right? What's your role in the team? At Stamford Health and also Greenwich, Norwalk, Bridgeport, all of our local hospitals are all teaching hospitals, which means that there are residents who are physicians, but they are having additional training And they work with the hospitalists as a team to provide care. When a patient comes into the hospital, depending on their illness and who's available, they may be cared for only by a hospitalist, or they may have a resident with the team. And it's always good to find out who's who. If you have a resident, that's actually a good thing because they are available a lot more. The hospitalist might go off to do administrative tasks or whatever, and the residents are the first call. If the nurses need something, they'll call the resident and they're expected to respond, so it's actually a good level of care. And then the resident is often the one who you see most often. They come in to see what's happening in the morning, what happened overnight, they might speak with the family more directly, so that's actually a good thing. So that's the medical team, and then the hospitalist team and maybe the residents, they may call in any specialists that they need, cardiologist, pulmonologist, geriatrician.
And what about some of the other folks? Because there are people who put hands on and do time-wise a lot of the care, and the big piece is whether it be at a hospital level, skilled nursing, discharge begins at admission.
Yeah, it's true.
Okay, so that means something to somebody. You said, is that true? That means all your coworkers think that way too.
Yeah, they do.
So what's going on and who's talking about my discharge while I'm being admitted and who should I be? Because that sounds like a pretty important person.
Yes, so first of all, just the nursing staff, right? Those are the people who are really taking care of the patient because they're there constantly, they're responding to anything needed, they're providing the care, medications, fluids, anything. So you have nurses, and then we also have CAs or CNAs who are aides, and those people are physically caring for the patient, cleaning them, turning them, getting them out of bed. So those people are really, really, really important to know. Most of you probably know that. And then in addition, the case manager and social worker, those are the people who start right away thinking about where is this person going to be able to go when they leave the hospital. So even if we don't know when you're going to be discharged, the case manager and social workers start thinking about it and working with the families right away, which can be alarming because you get the sense that they're trying to kick your loved one out of the hospital. We're just doing the planning because we don't want to be caught with Medicare saying, well, they're ready to leave, they're medically stable, but we don't have a plan for them, so we want to start that early. If they might need more care after being in the hospital, we want to be able to do that with you. At Stamford Hospital, case managers are responsible for a plan if the person is going home. An assisted living is considered home, that's your home, and the social worker is responsible if the person might go to a skilled nursing facility or rehab. That's important to say.
I just want to add also that the case management and social work is mandated services by Medicare. It's a condition of participation. The hospital for Medicare, they must provide the services. So when they come to see you, it's Medicare demands those services. Because
It's interesting because
Medicare demands that hospitals provide services of case management and social work.
I just wish that was mandated on the outside. I mean, the inside is such a short little period, feel so strongly that it should be mandated on the outside. But I wanted to also just touch also that, physical therapists and are also involved, and they'll be helping the team also with planning on discharge. It's gonna be, for people that are in the hospital for a week or 10 days, they're gonna be weaker. And there may be a change in function. So, assessment by physical and occupational therapists will be helpful to determine how safe it is for them to go home versus, a skilled nursing facility and what kind of equipment they might need upon discharge.
We at Medicare rely on physical therapy and other therapy services to determine whether somebody is eligible for that rehab stay after being. I order physical therapy for pretty much everyone I see.
So, but sometimes they're gonna go home, and even if they go to rehab, they're not gonna be there that long. I've gotten this news that she's going home. Things have changed. Somebody's just been through a traumatic experience, and they're probably not. And I've left the hospital. I don't have that hospitalist cell phone number. I don't have that case manager coming in, nurses are coming in and talking to me, and I'm all alone, Alison.
You're not alone. You're not alone. I mean, there is going to be a handoff upon discharge. For everything that we do in medicine, communication between the teams and all the players is going to be really critical. I know that when my patients go into the hospital, we are often talking about it, when they go, when they come back, and anywhere in between. So having that kind of, communication is important, and the transitions are really critical. So whenever a patient is discharged from the hospital, we get a clinical summary. Sometimes depending on the hospitalist, there may even be either a phone call or a text exchange letting me know, and so I know that we need to make contact on the outpatient side. With the transitions of care are times where people are very, very fragile and vulnerable. As you said, patients are being, they're not staying in the hospital until they're back to their baseline. It gets earlier and earlier, and they're still very much, physically disabled. So we have to make sure that, they have the right support at home, that, they're stable, they're not going back into the condition that, they presented with. So we do what's called a transition of care visit shortly after discharge. We're supposed to make as part of this visit, we're supposed to make a contact with the patients or the representative, within a couple days of discharge, find out if there's anything needed and set up, an appointment and how the, patient overall is doing. And at the transition of care visit, obviously we want to summarize kind of like what happened in the hospital, how is the patient doing now, are there things that, maybe are raising red flags for us that again, this condition may be surfacing again. We also really want to pay attention to the med list. In the hospital, a lot of times there are med changes. Perhaps medicines are started or medicines are discontinued. So we want to be aware of what's happened in the hospital. We want to make sure that whatever medicines are appropriate, upon discharge are they're still on the patient's med list. Or if they were not on the med list at discharge, that they're still not there. We basically, that time after a hospital stay is a very high risk time for somebody winding back up in the hospital. So those visits are critical.
So you raised 2 points. They're very different. We're going to get to formulary in a second. You made it seem as though it's really seamless and automated and great, and it's perfect communication from the hospitalist and the team in the hospital to my primary care. With all due respect, I don't think that really happens. And so as the caregiver, what should I be doing to ensure that? I don't think, nobody in medicine has ever been accused of over-communicating. So what is, as the primary caregiver, and I get forgotten sometimes, I'm the primary caregiver, what can I do to have that handoff? You guys work well together.
Well, it's just Dr.
How can I make
really
that
good
handoff
at this, but not all doctors and offices are.
Maybe, I don't know. I think, you also will get, the patient, their family will get a patient clinic, a patient discharge. So, that will have, what condition they were treated for, what, medicine changes there were, things like that. So I think it's important to review that, to ask any questions of the team before the patient is discharged.
Here's what I would recommend. So actually you should proactively call the primary care doctor as fast as possible. The other thing I'm going to say, which you can correct me if this is not accurate, under Medicare, the primary care doctor can actually bill a slightly higher code for doing a transition of care visit within 2 weeks. So most of the time you're going to call your primary care doctor, they're going to tell you that the next visit is like a month away, but tell the office this is a transition of care visit and they should put you in because they get to charge more for it. So that's to their advantage. Bring all your medications. I advocate for bringing all the medications in the bottles to every visit. But at least for the transition of care visit, bring all the bottles, or don't, not just the pill box, because it won't say which medications, so that the doctor can physically look at what you're actually taking and they can compare it to the list from the hospital. And then, so just the more proactive you are with, and then the more information you have, the better. That's what I would suggest. And then the other thing, just a word about care after being in the hospital. So people still have a recovery period. They're at high risk for more complications. We can't fix that because they just need this recovery period, but they can't stay in the hospital. So I always advocate to plan for more care than you had before. And it may be just for a transition period, and maybe you go back to the way you were before and everything you were able to do before after some period of being home. But coming home can be really challenging because you don't know if you can now go in the kitchen and get yourself a cup of coffee like you did before. So I really prefer for people to have somebody there with them, whether it's a family member or a hired caregiver. So planning for that when somebody goes home is really important.
Okay.
And also just making sure any equipment, again, that, you know, that maybe the physical therapist is recommending something like a raised toilet seat or, you know, a commode or whatever it may be. Just making sure that equipment is also kind of lined up. Usually the case manager will help you, yeah.
And again, discharge starts at admission, so I should be prepared for discharge right away and get all that stuff.
And think about.
And it's super easy to get, okay, maybe I'll say the wrong word, okay. It's not as challenging as you might think to line up a home, like, you know, if you don't have family in the area, there are lots of agencies, I mean, I'm sure you guys are in touch with a lot of them, but you can do this fairly quickly, and set things up, although, you know, a lot of us like to do it, you know, for our parents or our loved ones, but it might be too challenging.
It's always been that people get into those resources.
Yeah.
My mom went in, she was on 10 milligrams of this, now she's on 5 milligrams of that. So is she getting different medicine now? And why is that happening? And what should I do when she leaves? This is now what she's supposed to be getting? And so walk me through why there are changes, other than by treating what's there. But sometimes it just changes, and why?
So unfortunately, what we call medication reconciliation, which we are actually obligated to do by Medicare, which means that we look at the list of medications you're taking at home, what we give you in the hospital, and what you need to take at discharge to make sure that that all seems aligned and we don't miss anything or change anything. We are very bad at this, I'm sorry to say. And one of the big roles that our team tries to take is to actually go through the medication. So you might feel like you're being asked for that list 8 million times. That's also a good thing because we just really want to know that we're all on the same page. In the hospital, unfortunately, the pharmacy gets to choose which medications to stock at the hospital. So statins are a great example, the cholesterol medications, because we only have one type of statin at the hospital. So if you're taking a different one at home, we're going to give you what we have in the hospital. The biggest place where I see this being a risk for older people is with medications for urinary incontinence, because there are medications which are safer for the brain that are used for urinary incontinence and medications that are less safe, and you may be switched to one that is less safe. That's why it's so important for you to know what medications you were taking going in and really be clear about that. Have a list, bring the bottles. You could bring the bottles to the hospital to show the doctor, and then also look at that list given at discharge and compare them and make sure you go over that with the primary care doctor. So it's a lot of work, but I definitely advocate for that. I'm sorry, there was a question. I don't know if we're taking questions.
Sorry. We'll do,
if
we can, let's try and hold questions to the end.
I was just gonna ask though, is it something, so like in the nursing home, if somebody, like, if you think about these overactive bladder medicines, these incontinence medicines, can somebody bring in there? They can.
So if you have a medication that you take at home that we do not have on formulary at the hospital, you bring it to the hospital, give it to the nurse, and they will have the pharmacy validate it, and they can give it to you while you're in the hospital. Do not ever administer medications directly to your loved one by yourself in the hospital. That's dangerous because they won't know what you gave them, or they might give double, so bring it to the nurse.
I want to dive into some complicating things. The big one is, you know, my
my mom has cognitive impairment, she has, and now she's been in there a day and she's just not ready. The doctor said, oh, it's delirium. She got, I know she got it. No, she got it.
So delirium, I'm sure you guys
This is
have,
our favorite topic.
yeah, this is both of our favorite topic, but people call it, different things, acute confusional state, altered mental status, I've heard it called hospital dementia, that's what my sister-in-law calls it. It's basically it is an acute confusional state, that's often ties into a medical condition, a new medical condition, and that could be any number of things. It could be an infection, it could be a heart attack, it could be anything really, electrolyte change, kidney failure, you name it. It could be from a medicine. So you have this acute confusional state, you have this underlying condition causing it. Oftentimes you have changes in level of alertness. Somnolence, that can be, where you're sleeping all the time, you're awake for very short periods of time, you're very drowsy, or it could be on the completely other end of the spectrum, you could be bouncing up, off the walls, screaming, not, completely not yourself. So those are all features of delirium, and I try to really pay attention when a family tells me something's not right. Here I am on the outside, because a lot of times delirium starts on the outside. Sometimes it starts in the hospital, but sometimes, before the hospital. So when I get a phone call that, whoever it is having a change in, I really do want to get to the bottom of it. I want to know what are the associated symptoms. Are there fevers? Is there shortness of breath or cough or whatever? I'm trying to get vitals. I would love to see them if I can. I think physical contact in that kind of scenario is really important as well. Sometimes I'm trying to manage in home again, or wherever they are. We're trying to treat in place if they're not, acutely unstable. Maybe it is something like an infection, like a urinary infection, which you might be talking about, but where I do feel more comfortable, and I know that the preferences of the patient sometimes it's, they're a danger to themselves or to somebody else, or there's something really serious going on. Maybe they're having high temperatures, or their, oxygen level has dropped or whatever, and they need to go to the emergency room for an urgent evaluation.
So it's a geriatric emergency. There's a few things I want you to know about delirium. So I think of it as the brain being overwhelmed by everything else that's happening, whether it's a medical condition, change of environment. We see delirium sometimes even if people just switch caregivers. Constipation is a big driver of delirium, so you'd be amazed at how many things can cause it. Multifactorial, so it's not just one thing. It's the combination of factors that are happening to somebody who may be sick or hospitalized. It waxes and wanes. And so there can be up and down. There are times when that person might seem back to themselves and then they get worse again, and people are really scared by that. But that is the nature of delirium, is that it can come and go. Ultimately, we want people to get better. It is very common. It happens to a lot of people. So a lot of the patients we are seeing them because of delirium, but it is not normal. It's not a normal thing to have happen. It's actually can lead to poor outcomes and even increase the risk of mortality because there are different factors associated with it. People may not eat or drink well. They may be agitated, hallucinating. And then it is a risk factor for developing dementia. It can actually take weeks to months to resolve, and some people don't go back to the way they were before. So if you hear somebody say, well, mom developed dementia in the hospital, it's that they had delirium and maybe their brain did not recover completely. So that can happen. So that's why we take it really seriously. There's no medication that makes delirium better. We use medicines for symptoms. If people are not sleeping, if they're hallucinating, we have medication that can help treat them to get them more comfortable. The most important thing is to treat the underlying condition. Why we have to look so hard for what's causing it. The environment is what we want to normalize. We want people to have normal sleep-wake cycle, get out of bed, get moving, stay hydrated. We want to orient them, tell them where they are, what's going on. So those things really help the brain recover.
What are the so making them comfortable, and you mentioned is the brain getting overwhelmed, we're dealing with this situation. So I'm the caregiver, I'm standing there sort of helpless, but pretty powerful. So what can what can I do here while you figure out how to treat this underlying thing? Either something preventive, they've gone into the hospital, what is my role in that room? What can I do to that room? How can I stop these things from happening or impact them? And once they have happened, what should I do?
You take nothing else away. This is the critical piece, how you advocate and help that person.
Yeah, so I think the prevention of delirium and the treatment of delirium are very much the same. You just touched on a bunch. There are programs that we are instituting in the hospital to really screen for delirium and be able to address it in our patients quicker. As you had mentioned, the longer a delirium goes untreated, the more severe it is, the more severe the outcomes. It really is. But families, can play a critical role because, hospitals are generally, I don't want to say we're understaffed, but, like to focus, on one particular patient, like all of our energies, it's not realistic, So families can do that. They can reorient, and reorienting is something as simple as talking about current events or, talking about the day of the week or, what's going on in the family or just
Familiar things.
Just familiar things. And, they can, with the blessing of the team, offer, some drinks, maybe set up the food tray. There's lots of things that a family can do.
I mean, I would say that the role for families in the hospital is active and polite. So very active, order the food, make sure that the person has water at the bedside if it's okay with their medical condition, and the nurse will be able to tell you that. I suggest that people bring a clock or a calendar, like you could bring a calendar page in large format so that people are oriented to what day it is, and then stay with the person as much as possible. Take turns with other family members, or even consider hiring somebody if you can't be there yourself, which we welcome in the hospital. We want you to hire a caregiver to be with the person, because that hands-on one-to-one attention, we can never provide that, so that's a fabulous role for families. Certainly communicating with the team and the nurses to see if somebody needs to get up and get out of bed, to sit in the chair, get to the bathroom. So those are really great roles for the family members. At Stamford Hospital, you can order food at any time. You can pre-order meals, order what you know they like, help them eat it. Those kinds of things are really critical. So if you could summarize the points: orientation, hydration, and mobilization. So get people up and moving. We're not gonna let you do that by yourself. You have to call a staff member if somebody wants to get up and moving, because obviously we don't want anyone to fall. But still, it's okay to ask and say, can we get them in the chair now? Can we make that happen during the daytime? So those are some things, partner with the staff, introduce yourself. They will be grateful that you're there to help them with the care, as long as we're partnering together.
I think that's a good point too, is I talk to the staff about the person as the patient. So the staff now knows them beyond, it's Mrs. Jones in 305. It's Mrs. Jones who was the high school teacher at the local high school, who relates this, or loves talking about her dog, or this or that, so that when you're not there, staff can give them something familiar.
Exactly.
Now I want to pivot because I want to be sensitive to time, and I want to open the floor. The last thing I want to get out there though is a bit of a tangent, and it's the dilemma that we talk about in the senior population when we're making difficult decisions about whether a surgery is the right thing to do, or you mentioned before about CPR. So that's an easy entry as to whether we're doing CPR on a 95-year-old body and chest compressions. Okay, that's very easy to understand, but there are other decisions where I've broken my hip. I go in, and if I was 70 years old, well, I'm gonna be out tomorrow because you're gonna replace my hip and I'm good to go. But if I'm 95, it may not be best to do that. So what are some of the examples, and what are we thinking about there, and how should we address that as the care?
Tagging on your hip fracture thing, I mean, it kind of depends on what the person's mobility and functional status was before. I mean, there are times where people, will have chair bound, they're not mobile, they're not walking, and, you know, for one reason or another, because falls are like the other thing that we deal with a lot, but they have fallen and now they have broken their hip. Well, that's going, you know, their mobility before the hip fracture is going to be a factor in whether or not we're gonna be pursuing a hip fracture, you know, what their overall functional status, what their comorbidities are, you know, determining the risk as well.
So to me, this is a huge topic, and so I would definitely recommend consulting clinicians you trust to have this conversation. To me, the choice about almost anything we would want to do or not do is about the balance of the benefits, potential benefits and potential risks. And you can think about anything that way. Should we go to the hospital? Should we take this medication? Should we do this study? Should we have an MRI? Etc. So it's about balancing potential benefits and risks, and that is very individual. So it depends on what the person's lifestyle, quality of life, and functioning was like before. What are their wishes, right, if they didn't want a lot of intervention? And what will happen if we do this test, medication, study, whatever, if we do it, right, what might happen? What could be the potential complications and what could be the potential benefits? And if we don't do it, what are the potential benefits to the person or the risks of not doing it? Maybe if you don't do it, they won't walk again, right? But maybe if we don't do it, actually, it's not really gonna change a whole lot. So it depends on what you're talking about doing, but those are the things that you wanna balance. What are the alternatives? And if we choose an alternative, how will that affect me, right? What are gonna be the risks or side effects of doing that? So it's pretty complicated.
It is, I know, and I really appreciate that you guys would, on any one of these things, you could have spun out for an hour on each of them. And on this, to add somebody with cognitive impairment and just general anesthesia, depending on what we're gonna do, is gonna have an impact. And it's sort of fuzzy math on, we don't know.
Right, we don't know. So admitting that we don't know is actually really, really important, which I don't, you know, we don't always do that. But we don't know what the outcome is gonna be. We have to take our best understanding of what might happen and then make decisions based on that.
So again, thank you very much for being here. I wanna open it up to if anybody's got questions from the room, we'd be happy to do that. The one underlying thing of this whole series has been, though, these are local experts in there, and if we piqued interest in anything, have these conversations, start the conversation. No exam on this, life comes. You should now be proactive and go out and get other questions, get the expert. Don't just get it from your neighbor. Your neighbor must have loves you, does a great job, been through it, but it's different. It's whatever.
And there is a lot of misinformation out there.
Yeah.
I was just talking to somebody today, and you know, I think people tend to.
There's a lot of misperception. I just want to put in a small plug for our group. We're the Stamford Health Geriatrics group. We have more clinicians joining our group now, so we have more access to see people in the office for evaluation and these kinds of conversations.
So anybody have any questions in specifics?
I actually, a minor question, but I was just curious. You said if there's a medication that the hospital doesn't have, you can give them, but can they return that bottle to you, or should you count out?
So in theory, yes, the pharmacy should be able to give it back to you when they leave the hospital. In practice, there sometimes are these details of what actually happens when somebody is discharged. Sometimes things can get lost or misplaced. But the doctor is supposed to give you a prescription for the medications that you're being discharged if you want it, and so they should include your home medication. So even though that doctor in the hospital was not the one who prescribed it, they can give you a prescription for it when you're leaving, and we can even fill it at Stamford Health. We can fill it at the pharmacy in the hospital, the Walgreens in the hospital.
Is there a hospice section of the hospital?
We don't have a hospice specific section in Stamford Health. What we do offer is that if somebody needs to have hospice provided when they're still in the hospital, qualify for inpatient hospice, which means that they need a lot of management to keep them comfortable, then they can stay in usually the same room where they were, but now we have a hospice agency that comes and helps the clinicians in the hospital to make sure that they get the right hospice care. So it's not a special unit, but we do have the resources to do it if we need to.
It brings up two different hospice there. Inpatient hospice, which you have to qualify for, and hospice. Those are two very different. No. It's just different pieces of hospice. and there's hospice, and I can't even approach
Very
it.
important topic.
On the level that gets you in, there's a hospice house in Brantford,
Yeah.
so you can get it, places can be paid for, that
Yeah.
Medicare will pay for this, Cabrini in the Bronx will pay for it.
Three
Yeah, but
But you have
if you
to
go to a
qualify as
hospice house,
inpatient.
if you go to a hospice house, you pay for
Well,
room and
you
board.
pay for room and board, right, so 3 sentences on this. So first of all, hospice is a Medicare benefit, so if you have Medicare and you qualify for hospice, the hospice services, correct, are provided by Medicare. And that means the medication keep you comfortable, a nurse to check on you periodically and make sure you're comfortable, and then your family being able to call the nurses for guidance and work with them to figure out how to make you comfortable. The hands-on care, making sure that you're clean and fed and moved, that you pay for unless you have something that pays for it, like a long-term care or Medicaid. So those are 2 different pieces. Hospice can be provided anywhere, but wherever it is, those are the 2 pieces that we have to make sure you have. Does that make sense?
Again, thank you very much.